Diabetic ketoacidosis, or DKA, is a life-threatening medical emergency. Management must be structured and systematic. Diagnosis is usually made when blood glucose is above 250 milligrams per deciliter, arterial pH is below 7.3, bicarbonate is less than 18, ketones are positive, and the anion gap is elevated. Management begins with stabilization and monitoring. Always start with ABC, airway, breathing, and circulation, and ensure continuous cardiac monitoring, IV access, and frequent vital checks. Step 1 is fluid resuscitation, because most patients are severely dehydrated. Start 0.9% normal saline, about 1 to 1.5 liters in the first hour. After that, continue fluids based on blood pressure, hydration status, urine output, and corrected sodium. If sodium is low, continue normal saline. If sodium is normal or high, switch to 0.45% saline. When blood glucose falls to around 200 milligrams per deciliter, change to dextrose-containing fluid to avoid hypoglycemia while ketosis is still clearing. Step 2 is insulin therapy. Begin continuous IV regular insulin infusion, usually 0.1 units per kilogram per hour. A bolus is not always necessary if infusion is started appropriately. The goal is a gradual fall in blood glucose, about 50 to 70 milligrams per deciliter per hour. Insulin must never be started if potassium is severely low. Step 3 is potassium management. Even when serum potassium looks normal or high, total body potassium is depleted in DKA. If potassium is below 3.3, replace potassium first and delay insulin. If potassium is between 3.3 and 5.3, give potassium along with insulin and fluids. If potassium is above 5.3, do not give potassium initially, but monitor closely. Continuous ECG monitoring is extremely important. Bicarbonate therapy is generally avoided and may only be considered in very severe acidosis, typically when pH is less than 6.9. Now, what to monitor and how to monitor is crucial. Check vital signs frequently: heart rate, blood pressure, respiratory rate, oxygen saturation, and level of consciousness. Monitor blood glucose every hour. Check serum electrolytes, bicarbonate, and anion gap every 2 to 4 hours, along with ketone status. Monitor urine output carefully to assess hydration and kidney function. Look for complications such as hypoglycemia, hypokalemia, cerebral edema, and fluid overloads. DKA is considered resolved when blood glucose is near normal, pH is above 7.3, bicarbonate is above 18. The anion gap is closed, ketones are cleared, and the patient is clinically stable. Early recognition, structured treatment, and careful monitoring save lives.